Happy Pride Week, everyone, and welcome to Breaking Barriers, an event hosted by Dalhousie Medical Research Foundation in support of Pride and the 2SLGBTQ community. I'm your MC, Matthew King, and I'm the Director of Finance and Operations for Dalhousie Medical Research Foundation. Before we begin today, I would like to acknowledge that Dalhousie Medical Research Foundation is located in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq, and pay my respects to the elders. Today, we will be speaking with local health researchers and addressing health disparities that members of the 2SLGBTQ community face in this province. We stand with you today as allies and advocates. For those of you who don't know our organization, Dalhousie Medical Research Foundation, or DMRF, exists to raise funds to support local health research that has global impacts. For over 40 years, DMRF has raised tens of millions of dollars to support life-changing research that supports the betterment of whole human health, thanks to its donors. This research goes beyond test tubes and microscopes. However, those aspects are clearly important. The health research that DMRF donors support focuses on mental health, quality of life, access to care, women's health, faster diagnosis, along with treating and curing disease, all while considering diversity and vulnerable population. And that's why we're hosting this event today, because we all deserve good health. Over the next hour, you will be hearing from two local health researchers who care deeply about wellness as it relates to the 2SLGBTQ community, and who have focused great time and energy into addressing health disparities as they relate to vulnerable populations. We are proud to feature the leading edge work of Drs. OmiSoore Dryden and Matthew Newman. Please note that at the end of this session, there will be time for a Q&A. We encourage you to write any of your comments or questions in the Q&A box below as they come up. Now, I'm pleased to introduce Dr. OmiSoore Dryden. Dr. Dryden is an associate professor at Dalhousie University in the Department of Community Health and Epidemiology. As well, she is the James R. Johnston Chair in Black Canadian Studies. OmiSoore engages in interdisciplinary scholarship and research that focuses on Black LGBTQI people, blood donation, Black diasporic communities in Canada, and systematic and structural issues that affect their health and well-being. This includes medical education and critical race theory, along with developing Black health curricular content. Today, she will be discussing her work as the principal investigator of #GotBloodToGive, a research project that seeks to identify the barriers that Black, gay, bisexual, and trans men encounter with donating blood, and also analyzes how anti-Black racism, colonialism, and sexual exceptionalism shapes the blood system here in Canada. Without further ado, it is my pleasure to welcome OmiSoore.
Good afternoon. Thank you so much. I'm sharing my screen. I always get a little nervous with this, so please bear with me. Yeah, please bear with me. Share. Are we good? Let me just do this. Thank you. Chat. Perfect. Okay, I think I have everything ready to go. Thanks again for inviting me to present on my research. I'm starting my timer so I don't go over time, and please give me a 2-minute warning. So I too want to begin with acknowledging that I live, work, and study in Chibuktuk, Halifax, the traditional unceded territory of the Maliseet, whose ancestors, along with the Mi'kmaq and Passamaquoddy nations, signed peace and friendship treaties with the British Crown in the 1700s. Yet we must not forget that these treaties were signed roughly 140 years before the end of slavery in this region we now call Canada. I want to acknowledge both the custodians of the land. I want to acknowledge African Nova Scotian communities, and I want to acknowledge Black and Indigenous, queer, trans, and two-spirit ancestors who were here before us, here now, and who we are also engaging with. So thank you for that. Today I'm going to be just giving a really brief outline of Black queer diasporic analytics and LGBTQ health research. I will talk about my research project, Got Blood to Give, some initial data and next steps, and then I'll wrap up. It's a lot of work to do in 15 minutes, and so bear with me, and I'm happy we'll have questions at the end. I want to also acknowledge that one of my former research assistants who worked on this project is attending today, so I just want to say hello, bonjour to Vincent, and thank you all for everyone for attending today. So in order to understand how we do research, or how I do research in Black LGBTQ communities, and specifically around Black MSM, cis and trans, when it comes to blood donation, it was important to identify all of the questions on the donor questionnaire that impacted Black men who have sex with men and prevented them from donating blood. So we're all familiar with this question on the right when it comes to MSM blood deferrals, but few people are as familiar with these questions. But if we are actually going to talk about removing barriers to blood donation, then we can't limit ourselves to the singular notion of gayness. We need to understand the intersectional realities of Black queer and trans people, Black Spirit people, Black and Afro-Indigenous people. And in doing that in blood donation, it means also identifying these questions. This is why I put this here, to get a sense of intersectionality. Again, using critical race theory and Black queer diasporic analytics, we start from the understanding that racism exists. It's part of this colonial project. And that means we cannot talk about homophobia without also talking about racism. And as we know, these notions of normality and what's come up with early scientific framing of homosexuality came out of scientific racism. And so when talking about intersectionality, we need to remember to address race, racism, and the ways that Eurocentrism or white supremacy makes itself known in the work that we're doing, especially in health. If we're not looking at that, if we're claiming intersectionality without looking at how race shows up, then we're doing what Kimberly Crenshaw calls the gentrification of intersectionality. So when the donor questionnaire uploaded their questions to a computer, these are the images that they use to describe those questions around Africa. As we know with health promotion, when you add images, it is to further clarify the text, to help clarify the information that you're seeking from the participant. And so in my other work, I spend quite a bit of time talking about how damaging these images are and how it negatively impacts Black communities and Black queer communities, and how these questions have nothing to do with science, nothing to do with the claims that the donor questionnaire is based on science. These questions come out of a kind of scientific racist history, and we see it in a contemporary moment in blood donation. This is why it's important to understand that racism exists, identify that in our health research, specifically around LGBTQ health. And so my work looks at anti-Black homophobia, and I just a little time here in the ways in which Black, queer, and trans people are often relegated to the margins in larger health research. And that's not what my project does. My project, funded by Canadian Blood Services, is the only one funded that centers Black, queer, and trans communities. So ACB MSM is not an oxymoron, is a research project that explores the importance of African, Caribbean, and Black men who have sex with men and blood donation. It occurred over 4 sites: Halifax, Montreal, Ottawa, and Toronto. We just recently wrapped up the funding period while we're still working on some of the data. This is the research team, co-investigators, partners, project coordinators, and research assistants. So thanks again, Vincent, for attending. One of the things that you'll notice and what was difficult in our project is outside of Toronto, there aren't health organizations or services that focus specifically on Black queer communities. And so we worked with agencies and our work with them often meant that that's when they began to develop Black queer programming. It did not exist prior to, it did not exist in a structured way prior to our partnership with them. So the overall objective was to generate evidence to guide modifications to the current Canadian Blood Services donor criteria and questionnaire in order to facilitate greater participation by African, Caribbean, and Black men who have sex with men. We had 3 aims, and we included the importance of point of care testing, which at the time was newish, and there were some challenges on having ethics approvals across 3 jurisdictions in different sites and universities and health agencies. So the study employed a mixed methods approach, respondent-driven sampling, surveys, cognitive interviews, and the data analysis employed Black queer diasporic analytics. I can talk more about this, but again, it centers critical race theory, queer theory, and intersectionality in identifying and analyzing the data. Our target sample size for each of the 3 parts, Halifax, Montreal, Ottawa, and Toronto, for a total participant pool of 400. And I'll talk about how we did. So this was the participant eligibility. Participants needed to identify as either African, Caribbean, and or Black, living in one of these locations, being of this age, 18 in Montreal, 17 in Halifax, Ottawa, and Toronto, identify as man, male, or gender nonconforming, and someone who has sex with a man, male, or even one time. When we began the project, it was pre-COVID, so we were doing this work in person with research assistants across the 4 sites. And I'll talk a bit about how some of that changed once COVID hit and putting this online. So what we were able to do over the period of time, this is what we wanted and this is what we got. We're very excited about where we ended up. And it's important to note here that this now becomes the largest health research project that focuses on Black, queer, and trans people in Canada. And I'll talk a bit more about that later, but right now our project stands as one of the few, maybe 2 out of 3, semi-national projects or projects that look at Black, queer, and trans communities. So just some preliminary data or some of the things that we collected, information we collected in terms of what was your sex at birth. I'm sorry the colors didn't show up as I had hoped. Toronto is green, Ottawa is yellow, Montreal is like a gray, white, and Halifax is red. And we felt that it was important that because we were doing this project on blood, that we also capture as much information as we could about our participants. How do participants identify at the time they were taking the survey? And here we see that there's quite a bit of range, but all that fall within the eligibility criteria. Our project again was about blood, but in that we wanted to identify HIV and engagement around HIV testing. The claims made by Canadian Blood Services is that people born in or living in Africa, or men who have sex with men, or for our case, Black MSM, that they were the vectors of HIV and AIDS, which is why they were not allowed to donate blood. And so we wanted to be able to identify that if we looked at behavior and we did testing at the time, that what we would identify is that there were way more people who were eligible to donate blood and that would keep the blood supply safe. So we were also troubling these definitions of what makes a safe blood supply. What we have noticed, and many people will tell you this, is people do donate blood and then stop donating blood because of the donor questionnaire. And people also come into their gayness at different times in their lives. So we're donating blood. I came out as gay and then stopped donating blood or slowed down donating blood. And so we wanted to get a sense of who was donating blood and when and where and why. And then why they donated blood. And these are various amounts of questions. And this is a good measure because it mirrors why the general public donates blood. And it also identifies that Black, queer, and trans communities are also encouraged and wanting to participate in this life-giving process. And then this question, what, if you're not donating blood, why aren't you? And these are really good measures as well in terms of, not being asked, not being allowed. These two were really, really important. And also taking a stand around wanting Canadian Blood Services to move to a behavior model instead of an identity model in donating blood. So AIM 2 and 3 really looked at more cognitive interviews, a reflection of Canadian Blood Services donor questionnaire, the images, also asking, what could Canadian Blood Services do to make amends specifically to Black, queer, and trans communities? So not just, predominantly white, queer, and trans communities, but also having to acknowledge and address how systemic anti-Black racism and anti-Black homophobia is unique in its positioning and has caused harm in Black, queer, and trans communities. And then AIM 3 was reviewing a sample questionnaire that we were creating to give to Canadian Blood Services to say, here are the types of questions we think you should be asking on the donor questionnaire. Again, something that's gender neutral, culturally neutral, or anti-racist at its best, and behavior, focused on behavior instead of identity. What we know through COVID is it is about behavior and not people. And every time we focus on particular people as being the cause of an epidemic or a pandemic, that only further and perpetuates harm, stigma, and stereotypes, at its worst, racism and racist homophobia. And so why it's always important to think about behavior and how to provide supports to help people modify behavior if necessary. So some of the challenges, I just wanted to talk about some of the challenges. Working over, it was supposed to be a 2-year project, we extended it to 3.5. Working over 4 ethics boards in 3 provinces, having to develop new research methods, respondent-driven sampling, and starfish sampling did not work in Black MSM communities. Respondent-driven sampling, it's believed, reaches out to hard to reach communities. However, it does not take into account how Blackness and white supremacy works in diverse locations in the country. And so we're in the midst of developing a modified starfish sampling model when the pandemic happened. And so we had to move everything online. And then in doing that and moving the survey online, we weren't able to screen for Blackness in the way that we had before, or for queerness for that matter. And so our numbers shifted because there were a number of people who claimed that they were Black, but then in the comments wrote really racist things. And so this is the second project I've worked on that's had to be online, that's focused on Black communities, where we were trolled by non-Black people as a way to try and damage some of the data. And these are the things we need to think about when we're doing Black, queer research and Black research. These are some of the challenges that also need to be taken into consideration. And so some of our initial accomplishments, as I said, this is the largest Black MSM research project data to date in Canada, Montreal, Halifax, and Ottawa, and Toronto combined. The next study was 168 Canadian-born immigrant Black gay men and other men with sex with men at aged 18 and over, which was completed in 2012. We brought attention to anti-Black homophobia and health practices, including blood donation. Question 30 has been removed. And it's important to note that that question on Africa, while it's been removed, is not full accountability. There still needs to be public statements around anti-Black racism, anti-Black homophobia, and accountability by the Blood Agency. The Blood Agency has made it known that they will be removing the question that bars men who have sex with men and moving to a behavioral model. And again, they're interested in making a statement about that, but that doesn't necessarily address, that won't address the anti-Black racism. And of course, developing new research methods for working in Black, queer, and trans communities. And I was just a little over. I know that was a lot and I rushed through that, but thank you very much. I'm looking forward to our question and answers. Answer section, this is where you can find me. I'm at Dal. And yes, I'm also the James R. Johnston Chair in Black Canadian Studies. And I'm the first queer person to hold that chair and it's now in the Faculty of Medicine. And so this work and more of this work on Black queer health in Nova Scotia and across the country is something I'm very excited about. So thank you for inviting me here today.
Thank you, OmiSoore. We really appreciate the important work you are doing in an area that needs much more awareness. If you have questions for Dr. Dryden, she will address them at the end of this event. Please write them in the Q&A box below. Next, I'm pleased to introduce Dr. Matthew Newmer. Matthew is a professor and head of the Division of Health Promotion at Dalhousie University and cross-appointed to the Gender and Women's Studies program. His research interests include sexual health among two-spirit, gay, bi, trans, and queer men, substance use, online technologies, and Indigenous boys and men's sexual health. Matthew serves on the AIDS Coalition of Nova Scotia, Gay Men's Health Advisory Committee, and as a regional advisor for the Community-Based Research Center for Gay Men's Health. Matthew is also a chair of the PrEP Action Committee in Nova Scotia. Today, he will be discussing his work at the Dalhousie Sexual Health and Gender Lab, or also known as the Dalhousie SHaG Lab, an umbrella under which he and associated students research LGBTQ health, sexualized violence, Indigenous boys and men's health, and e-learning. Over to you, Matthew.
Great, thanks, Matt, and thanks, Dr. Dryden, for that excellent presentation. Just give me one moment while I also share my screen. Perfect. Awesome. So today I'm just going to talk about some of the projects that we have underway in the SHaG Lab. As I said, stands for Sexual Health and Gender Lab. And a lot of this crosses into different areas. So I wanted to give an overview of what we do, and we certainly have more information available on our social media and soon on our up and coming webpage. So this is who I am, as was stated earlier, but also there you can find some of our social media. I give a shout out to all of my grad students who run my social media because they are much better at it than I am. And this week we're featuring the Community-Based Research Center, who has established an excellent program of community-based interventions here in Nova Scotia and across Canada. So what is the SHaG Lab? As we said, it's sort of this umbrella organization within Dalhousie that is my lab, that we have a number of different projects. We also really try to support grad students, particularly in the areas of queer and sexual health. And to really support them, I find that grad students tend to be much more creative and innovative than I am. So it's always a pleasure to work with them. So today I'm going to talk about 4 of the major projects that we have on the go in the SHaG Lab. The first is now called Wired Sex. The Wired Sex project originated a number of years ago when we did a pretty, it was a relatively small study of gay, bi, trans, and queer men's experiences of Grindr in Halifax. And and sort of how that contributed to a sense of community, connection, and so on. That was our initial early project. And we have a community report. Once again, if you email me right now, I can provide that to you, but soon it'll be hosted on our website, which should be live in the next couple of weeks. Out of that study, we recognized that a number of different substances, drugs, and so on were at play on these online platforms, whether it be, the hookup apps, Grindr, Scruff, and so on, or the web-based apps, the different ones that we use there. And so we wanted to sort of investigate what drugs and all their forms, so not just, the ones that we commonly know of, weed or cocaine, but everything, all the way from everything that impacts, we'll call it queer men's health. So we did steroids, we looked at meth. I mean, we did the whole range of it. And the reason is because we knew that these substances were also contributing to how we saw people and our identities in virtual space. So this project was funded by CIHR, the Canadian Institutes of Health Research. And primarily, we wanted to look at how we could reduce HIV stigma and HIV transmission, as well as other STD/VIs. But we didn't want to do that in a vacuum. We never really approached those issues as if it's just having safer sex or something like that. Rather, what we always realize is that, our sexual practices are influenced by greater social factors, homophobia, transphobia, racism, and so on. And so if we think about building community and understanding what either drives substance use or the ways in which substance use can sometimes even be beneficial, then we can start to unpack ways in which we can provide better harm reduction strategies and so on. So we conducted this study in 3 parts. We did a scoping review to understand what information was out there. Then we went, well, we didn't go, but we phoned up service providers across the country who worked with queer men and issues around substance use. And from that angle, we really got insight into some of the heavier forms of substance use, because these were the men that were often seeking help. And then we did interviews with men in Halifax, Ottawa, and Vancouver, 20 in Halifax, 20 in Ottawa, and 10 in Vancouver, who had in some way used substances and met up with people online, whether those substances were used in person or while they were using the hookup apps. Either way, they qualified for the study. So there are a lot of findings that came out of this, and right now we are wrapping up the community report for this, which will be available probably in about a month's time once we have the graphic design work done. But one of the major findings was that online tech provides a space for queer men to communicate and negotiate their interests. Being able to describe and interact and talk with people ahead of time, not only in terms of sex, but also in interest, substance use, and so on, creates an ability for some of that to be negotiated. Not to say that things like consent are once and for all, but it is to say that people have a general expectation when they do meet up in person. It also provided access for social and sexual networks. And so it also drives us to think about a new way of understanding community. One of the things we see is the dissolution of a lot of physical community spaces across Canada where queer people historically have met, and a lot of people have moved online. But there were, we balance that also with understanding that drugs can also facilitate psychological and harm and drug dependency. But online apps can also create a forum for support and promotion of safe and healthier drug use. And we can do this through employing harm reduction strategies. This can also be a place where, prevention strategies are emphasized, PrEP and others, and thinking beyond the historical condoms only mantra that's been out there. And then I think another important thing that came out of this was emphasizing consent practices where both sex, drug use, and other aspects of these encounters can be negotiated and teased out. Certainly sexual consent is a really important aspect of this. Nearly all of our men in this study in some way had experienced some form of sexualized violence or harassment. And we're moving in the direction of researching that further in our next study. Great. So the second project I'll talk about is our Indigenous Boys and Men's Sexual Health Project. This grew out of community organizations approaching us and talking about the need for this particular area of research. While the Wired Sex Project is nearly wrapped up, this one is really at the beginning. We did a small pilot study in the last 2 years, which we have a community report available for that one. But now we're about to embark on hosting major gatherings in partnership with Healing Our Nations and the Mi'kmaq Native Friendship Center to gain insight into boys and men's experiences of sexual health, masculinity, and so on. To date, we've interviewed stakeholders, and we've also talked to a small sample of Indigenous men who are accessing social programs at the Mi'kmaq Native Friendship Center. So while this project isn't specifically aimed at Two-Spirit people or other queer men, we did emphasize creating space within all of our research for a nuanced understanding of sexual orientation, gender identity, and gender itself. And so we really wanted to ensure that all of our research creates space for queer people to participate and not to be an afterthought, that we, actively recruit diverse groups, even within something like Indigenous communities. So the third area that I want to talk about today is our program of research on sex and sex education. And many of our projects do involve online technologies or technology of some sort. So in this one, we surveyed undergraduates' opinions in what was my human sexuality class. It's being taught currently by someone else once it's moved online anyway. And so we were looking at everyday attitudes, beliefs, and practices around two issues: sexual orientation and sexual consent. And the major findings from, we really wanted to challenge students on this because there's been a lot of talk out there about sexual orientation being, Lady Gaga's born this way and ideas like that. And so we wanted to really dive into, whether we were born this way and how that influenced undergraduate students' perceptions of non-heterosexual people. And then we also challenged them to think about whether, we had a shared experience within the queer communities. And this one, they really had to dive into their critical thinking to say, okay, well, sure, not everybody's experiences are the same, but then also we got a lot of responses about how we do often have shared experience across queer identity because of the effects of homophobia, transphobia, and heterosexism. And largely the attitudes and beliefs are shaped by the cultures that we live in. Okay, down to the last one, and this is PrEP advocacy in Nova Scotia. Every chance I get when I have a forum, I like to bring this up. You might have heard at the beginning that I was chair of the PrEP Action Committee. We haven't been as active since COVID started, but we are about to re-engage, especially now that we have a new government, in attempts to get public funding for pre-exposure prophylaxis. For those of you who don't know, this is a drug that can be taken either incidentally or every day to prevent the transmission of HIV. A number of years ago, this committee, or probably about 3 years ago now, this committee advocated the Liberal government to fund PrEP through the government so that it was available to everyone that needed it, obviously prescribed and in consultation with physicians. They did list it on the PharmaCare formulary, which allowed very few people access to this drug. And what we know about this drug is, though it is a bit expensive, people aren't going to pay for it out of pocket unless they have private insurance. But if it's publicly available, it markedly reduces the transmission of HIV. It is publicly funded in about 6 provinces, and we're hoping that Nova Scotia will be the next one. And we'll see. But we're out there and we're advocating for it. And we do have a paper published on physicians' readiness to prescribe PrEP in Nova Scotia. We can send that along to you if you're interested. But I think the most important thing is first removing barriers to access, and then, you know, educating and finding out who can use it and who it will work for. So those are the areas of research that I'm involved in at the moment. And always there are a number of other projects that my grad students, like I said, are taking up and doing, and it's always exciting to work with them as well. So thanks to all of those people who have worked on these projects and so on. So with that, I will end.
Thank you, Matthew, for taking the time to join us today and discussing SHaG and the critical work you're doing to address health disparities for this community. As we head into our live question and answer period, I want to thank our viewers who have been engaging with us during this live event. Now we'll begin to answer some of your questions. If you have additional questions, please continue to ask them in the Q&A box below, and we will do our best to answer as many questions as time permits. The first question I'll ask today is, how is Nova Scotia different than any other province when it comes to the health disparities facing this community?
I guess I will take the first crack at that one. That's tricky. I think that, you know, we are similar yet different in many ways. You'll see a lot of the common threads that exist out there, but Nova Scotia tends to have a quiet way about, well, often a quiet way about, you know, conducting its racism or its homophobia or its transphobia. We like to always think of ourselves as quite polite and that everyone gets along, but in reality, there's often these undercurrents that you hear, particularly centered around gender. And it's harder to actually advocate a lot of times when those forces and attitudes and beliefs are relatively underground and quiet, because, you know, it gets ingrained in society, and those kind of social attitudes and perceptions are, you know, more difficult to fight against if everybody thinks, you know, everything's okay, that, we won the right to marriage years ago, so all of our problems were solved. And if we just did that, then it's fine. But the reality of it is, you know, if we look at health outcomes, there's still a huge disparity in our communities. And that tells me that it isn't just okay, and that there is still this undercurrent. And particularly, I know I have one student who's going to start a project on queer rural health, as particularly for non-binary people, and what that experience is like when you get outside the city and there aren't any resources and you think you're the only person that's out there. So, you know, that might be one way that we're unique.
Yeah, that's so great. Thank you for that, Matthew. I'm new to Nova Scotia, so I'm not sure if I can actually be like, oh, here are all the huge differences. And plus, I, came out of Toronto. One of the things I did notice when we began our project, Got Blood to Give, was the difficulties I had in getting permission to use point of care testing in Halifax for part of the project. So we wanted to have people use point of care testing at time of interview, and then point of care testing 3 months later. And so we had to go through quite a bit of red tape, right? So not just ethics, but really, it felt to me excessive compared to the ethics review we went through in Montreal and the ethics review we went through in Toronto and Ottawa. And part of that was because of the way that point of care testing wasn't being used in Nova Scotia, while it was being used in many other jurisdictions in Canada. And what I felt was a hesitation to actually trust the efficacy of point of care testing. So that was odd to me in terms of, we have spent a lot of time in queer communities saying, know your status, right? And do that as a point of empowerment. So we could be really clear about how we care for our health. And that's been particularly unique in Black queer communities because of the way in which HIV has been stigmatized in Black communities and Black queer communities. And then the other piece was not having as easy access to anonymous testing. And so, on one hand, it was claimed that people weren't requesting anonymous testing, but on the other hand, it was like, but we have to break the seal and identify people and report them to the infectious disease unit. And none of that is conducive to being proactive around one's health. And so I think there are these conversations we need to have around how can we minimize and disrupt the stigma around HIV? And how can we do that by opening up the various ways that we can know our status and have that be empowered, right? So I'm hoping some of the impacts of COVID, as terrible as COVID has been, right now you can go down to the convention center and take home self-testing kits, right? Is there a way that we can be that forthcoming around point of care testing? And I know there's a study right now around having self-testing kits and how, what kinds of supports we can do with that. But I think we need to be more courageous around, trying something new or outside of the box, instead of so conservative when it comes to the health concerns of queer and trans communities, disparate communities, and Black queer and trans communities.
Thank you. Do either of you know of any future plans for research that focuses specifically on two-spirit, trans, or non-binary people?
So in my lab, we don't have a specific project right now. One of my grad students is starting a research project on specifically rural non-binary folks. So that one would be there. And then I would say that, while we don't have a specific project aimed, I mean, we may in the future, but we strive to make sure that we have good representation across gender identities within the category of queer men. I think in Halifax, we had nearly 50% of the people that came forward identified as non-cisgendered men. So, yeah.
I know for my colleague, the University of Toronto, Dr. Roberta Timothy has a national and international project on Black health equity looking about COVID. And in that project, there's quite detailed questions around sexual identity, gender identity, and sexual health. So I would consider that a project on trans communities. So it's not, as I said, it's national and international. So it's looking at Ghana, Caribbean region, the United States and Canada, the international piece. So that's what, oh, somebody's saying it's freezing. Have I frozen? Can you hear me? No, okay. So there's that project. I do know that there are a few people working with Canadian Blood Services around removing barriers for trans people to donate blood. From what I understand, though, they're predominantly white, and it does not focus on, from what I could see or what I understand, kind of intersections with two-spirit or racialized trans people. My project does. My project centered Black trans men as well. So those are what I'm aware of. And then, of course, there's a trans pulse survey that's been happening a couple of times. I don't know if there's a new version of that.
Awesome, thank you. That's a good segue into another question that has come in, and it says, what are some resources that other health researchers can use to ensure their work is more inclusive?
I made Matthew go first twice, so maybe I'll go. You've been very kind, so thank you. Something that Matthew just said, and I agree with it always. I think it's important to always include questions around ethno-racial identities, always include questions, so offering identities from which to choose a singular identity, and then adding a question around self-identification. I think we need to connect with what we currently know out of Stats Can, and be able to do these kind of comparative analyses, and be able to connect that with also sexual identity and gender identity, and also issues around disability and various abilities. So class, all of these things. So if we think about the social determinants of health, I think that that's important to include those questions that mirror that. And then there should always be a question around how colonialism and racism have impacted people's life and therefore have impacted their health. So that can be a question as well. So I think that also is important. And that's just about if you're doing survey work. Those are questions I would also ask in terms of focus groups, but be very cautious around who's in the focus group so that people aren't saying that's just your opinion or that's just your perspective and racism isn't an issue. So you really want to think about how the focus groups are being structured. And then where you're sharing the information. How are you tapping into Black and Indigenous, queer, trans, and two-spirit communities? So it's not simply enough just to put a link online and then ask the questions, but you do need to work in community and with community agencies. It's hard to do that pretty much outside of Ontario and Quebec, but in community agencies that focus on or work with Black and Indigenous, two-spirit, and queer and trans communities. So I think if we really want to say, like, this is the experience queer and trans communities are having, we need to then make sure that we're actually capturing the experience of queer and trans communities, and that includes two-spirit, Indigenous, and Black communities and racialized communities. So that's what I would suggest.
Yeah, and to add on to that, I mean, almost all of my work is qualitative, and a lot of it interacts with technology. And in advance, we ensure that we have those questions prepared so that we can know who our participants are, and so that we're not sitting in an interview situation where we're asking for, going through a laundry list of identities and all sorts of things. We want people to have the time to identify how they want and to contemplate that. And then I also think, it's the responsibility, I hear a lot from research, I just don't know about that stuff. And I think it's the responsibility of every researcher that's out there to get educated. It isn't good enough anymore to say, well, I don't do that kind of research, so it doesn't apply. It does apply. And, by not naming and not understanding different identities within either surveys or other research, we're in fact silencing those groups. So, over COVID, I got a call from somebody and it was great. It was the best of intentions. They were like, well, we want to do this ergonomic survey. How do I ask questions about race and sexual orientation and gender identity? And at first glance, you wouldn't think that had anything to do with it. But we know that, queer and trans people and folks within our community have had a negative experience with COVID beyond the general population. And why is that, right? Isolation, all of these other sort of things. And so it's important to ask the question, even when we don't think it counts. Yeah, and to get educated about this stuff. It isn't good enough just to have a guest speaker come in anymore, or, just to have the token whomever. We actually need everyone to start to think about getting educated about these complicated issues.
I could, oh my gosh, I could talk about it for so long, right? Like what you just said. And then also methods. We need to look at methods. This is a thing we learned with respondent-driven sampling. Everyone was like, oh, that'll be great. And it wasn't. It really made us kind of sit down and think, okay, how are we going to reach our own community? And so the idea that methods are universal and are effective for everyone is a systemic barrier. And so we do need to be creative. And I agree, Matthew, I'm always a little taken aback, whether it's epidemiologists or health researchers or others who are like, you know, we can do this work without having to address race, or we're colorblind, or we treat everyone the same. And that is just not the case, right? If it were the case, we would have much more you know, research, many more research projects that focus on the experiences that Black, queer, and trans people have in health, right? The Black lesbians have in health, the Black trans people have in terms of genital health, right? Pap test, prostate, right? We would have these studies that would look at the intersectional experiences that can be harmful and be barriers, and we don't. And as we know, CIHR is just now looking at removing the systemic barriers that have prevented Black health researchers to get the funding that they need to do these projects, right? And so these are also barriers. So I'm, you know, just again, I could talk about it for a while.
Yeah, I mean, one of the things we did was not just put a link out there. We consulted with community leaders. We found out when we were doing recruitment for some of our studies, you know, where the groups were on Facebook, and, you know, did some targeting. But we also approached it with a bit of humility to say that, you know, when you're researching these very stigmatized topics like sex, HIV, drugs, and so on, that, you know, when communities, particularly racialized communities, have experienced multiple layers of oppression, they're not always going to be able to come forward and speak to that thing. So I think the methods that Dr. Dryden's talking about are hugely important, that we find innovative ways to give voice where our traditional mechanisms that have, you know, been quote mainstream or whatever, haven't always been successful at getting the voices of marginalized communities.
Awesome. I'll end the Q&A session with one final question as we continue to wrap up. But considering the health equities that exist in Nova Scotia, if you had a magic wand and unlimited funding, what kind of policies, services, clinics would address the needs of the communities? And how could additional funding help your research?
Hi, Gabriel. How do you even begin? Oh my gosh. I was thinking of something that Matthew was saying in terms of how do we provide better services in remote communities, right? How do we do that? How do we do that for queer and trans populations, Indigenous, Two-Spirit, Black, queer, and trans populations? How do we do that? And I also like the framing of, you know, stigmatized topics. So how do we really kind of, you know, get into that and, you know, just detangle it so we could just have these conversations without stigma or shame. Some of that is money. I think some of that is, you know, community people are doing great community work. And we saw that again through COVID and mutual aid and community accountability, where folks were working with each other to provide services they weren't getting from the state. And so while I do think, you know, we should think about more rural services, because I think that is directly important, I also think that I'm sorry, my window's open, it's pouring rain, so I'm hoping that's not too distracting. The kind of public health messaging that's plain talk, that tries to also disrupt some of the shame and stigma around you know, these stigmatized topics. It's the thing we said to Canadian Blood Services. If when you began in 1998, you actually started having conversations about sexual behavior and practices people were engaged in, then we would be at a different place some 22 years later, 23 years later, when it comes to blood donation. I firmly believe this. And it would have been a more fulsome conversation around what kind of sex are you having, and how, if in any way, does it impact the blood supply? And so I'm really encouraging of having just open conversation. And we need to really rely on what community members are doing with each other to further and expand that. That's just one of the things I would suggest.
Yeah, I think there are endless answers to that one, but I think that, the best interventions that we've seen across communities are the ones that are sustained and take into account multiple things that might be impacting people's experiences. So, if we're trying to do a sexual health intervention, it can't just be, that we go out there and give out condoms, or we, get people in touch to get PrEP, or whatever it might be. What we actually need to do is support communities. And there are no shortage of people out there who want to do good work, but often there isn't funding, there aren't positions, there aren't avenues through which they can do it without, giving up their entire lives. I mean, I've done a fair bit of, activism over the years, and I can tell you that I've had to go in and out of it because it's exhausting, right? I mean, and so if we were supporting communities better, and we were providing more sort of wraparound and services and community-based services, then I think we know those kind of interventions just do better than one-offs or, singular projects and things like that. So that would be my answer. Yeah.
Awesome. Thank you both, OmiSoore and Matthew, and thank the audience for your questions. We did today, but if there is any question that you would like answered, feel free to reach out to us or the researchers here with us today, and we'll also try to connect you guys to get your questions answered. As we round out the end of this noon hour, I want to really take this time now to announce that DMRF has created a special 2-year research grant called the DMRF Breaking Barriers Grant, which will award the recipient $25,000 in funding each year towards fostering and developing more critical responsive knowledge, capacity, and programs that address health disparities faced by the 2SLGBTQ+ communities in Nova Scotia and assist in the battle to overcome them. The competition for this grant is open to Dalhousie University faculty and will begin accepting submissions today with a deadline of Monday, September 20th, 2021. For more information, I encourage you to visit our website at dmrf.ca and click on the awards and grants section to download the application form. We are proud to offer this grant because we understand the power health research has to change and save lives. At DMRF, we are continually committed to supporting research that allows each of us to have access to care within a medical community that understands our unique needs, regardless of race, gender, or sexual orientation. To learn more about this award and the other local health research projects we support, please visit our website or follow us on Facebook, Instagram, Twitter, and LinkedIn. Also, if you'd like to watch this event again, it will be available this coming Saturday. We will be posting the link on our website and via our social media channels. This concludes our event today, Breaking Barriers, the fight against 2SLGBTQ+ health disparities in Nova Scotia. On behalf of DMRF, I want to thank all of you for joining us today. Thank you again to our presenters, Dr. OmiSoore Dryden and Dr. Matthew. I'd also like to give a special thanks to the many donors who have given so generously to the local health research we support over the last 40 years. Your support is making an important difference. Thank you again, and have a great Pride weekend.